So I want you to imagine an institution, right? A massive government institution that has done exactly one vital physical job
Right.
every single day for like 183 years.
Which is an incredibly long time for any American institution.
Yeah. I mean, think about it. Through the Civil War,
Mm.
the Great Depression, 2 World Wars, countless, monumental shifts in society. And this institution just kept doing the physical grinding work it was mandated to do.
Mm-hmm.
And you probably assume, right, that a government structure with that kind of historical inertia is basically invincible.
You would think it's a permanent fixture.
Exactly, a permanent fixture. But then, in the span of just a few months, the doors are locked.
Mm-hmm.
The massive brick-and-mortar buildings where all that centuries-old work happened are they're taken away.
Just gone.
Yeah, and the people inside are basically told to pack up. And, it sounds like this sudden catastrophic collapse, but the reality, this is what we're getting into today, the reality is far more methodical.
It really is. It forces us to reconsider what permanence actually means, in the context of government infrastructure.
Right.
Because what we are looking at today in this deep dive is the dismantling of the U.S. Public Health Service's direct care hospital system, specifically between 1965 and 1981.
Yeah.
And like you said, this wasn't some explosive destruction. It's really the story of a 183-year-old mission being slowly, quietly starved of funds.
Just chipped away at.
Exactly. Politically outmaneuvered and eventually shuttered by whoever happened to hold the budget.
Right. So we are tracing that long, slow diminishment today. And to do that, we've got a really deeply researched historical dossier we're working from. We're looking at public domain federal records, the actual text of the Omnibus Budget Reconciliation Act of 1981.
The big one.
The big one, yeah. And a really seminal 1983 account from the New England Journal of Medicine, which documented the aftermath of all this.
Yeah, that article is crucial.
It really is.
Yeah.
And we're also examining institutional histories that detail the shifting priorities of American medical research. And, the goal here today is to be incredibly measured and, humane about this.
Absolutely.
We need to look at the bureaucratic realities, like how money shifted from frontline, hands-on care to high-tech laboratory research.
Yeah.
But we also really have to examine the human consequences here.
Right. The real people.
Yeah. The merchant seamen, the urban poor, and the uniformed medical officers who literally lost their clinical home.
And a guiding thread for this entire discussion, something you really need to keep in mind as you're listening, is the flow of federal money.
The money trail.
Always follow the money. The true story here isn't that public health funding evaporated, right?
Right.
It's that the funding migrated. It moved. And following that migration reveals the mechanics of how our modern medical landscape was engineered and how an old system was just left to wither on the vine.
Yeah, left to wither. So let's start at the foundation. Because to understand how a massive system like this is dismantled, we really have to understand the specific economic and social mechanics that required it to be built in the first place.
You have to know what it was before you can understand how it died.
Exactly. The Public Health Service didn't just appear out of nowhere in the 1900s. It goes all the way back to 1798.
1798.
John Adams is president.
Yeah.
The United States is this, barely functioning republic, and they established the Marine Hospital Service. Which begs the question, why merchant seamen? Why did the early federal government care so deeply about sailors?
Well, you have to picture the economy back then. In 1798, the United States economy was almost entirely maritime.
Right. It was all ships.
It was all ships. The young nation depended absolutely on the flow of goods into and out of its port cities, places like, Boston, Baltimore, Philadelphia.
Mm.
The ships didn't sail, the customs revenues stopped. And if that stopped, the federal government essentially went bankrupt. It was that fragile.
Well, okay.
But the problem was that the men sailing those ships were doing incredibly dangerous, disease-ridden work. I mean, they were transient. When a sailor broke his leg in the rigging or contracted yellow fever down in the West Indies, the ship would eventually dock in Boston or Baltimore, and the captain would just discharge him.
You're fired, get off my ship.
Exactly, left on the docks.
And the local municipalities, they wouldn't take them in.
No, they had no incentive to. These sailors, they didn't pay local taxes, and the local almshouses or, charity hospitals were already completely overwhelmed with their own destitute populations.
Right, they're like, we have our own problems. We can't take care of this random sailor from halfway across the world.
Exactly. And furthermore, these sailors were vectors for communicable diseases. So the federal government, and this was really championed by figures like Alexander Hamilton, they realized that protecting the health of these sailors was literally a matter of national security.
National security and economic survival.
Yes. So Congress passed the Act for the Relief of Sick and Disabled Seamen in 1798. And that established a system of marine hospitals.
And this was funded by what was essentially the nation's first payroll tax, right? Like a deduction of 20 cents a month from the sailors' wages.
Yeah, exactly right. 20 cents a month. It created this dedicated, albeit pretty small, funding stream to build and operate physical brick-and-mortar hospitals in these port cities.
Which is wild to think about.
And for nearly 2 centuries, the federal government ran this chain of actual hospitals to fulfill this duty. The Marine Hospital Service eventually evolved into what we know as the Public Health Service.
Right.
And their mandate expanded slightly over the decades to catch populations that kind of fell through the cracks.
Like who?
Coast Guard personnel, certain civil servants, and crucially, and this is a big point for later, the urban poor living in those port cities where the hospitals were located.
Because the buildings are already there.
Exactly. They became an early specialized safety net for those neighborhoods.
Okay, so you have 2 centuries of delivering care. But the turning point, according to the dossier, isn't a massive budget cut. The turning point that sets up the demise of this whole hospital system happens in 1965.
Yes. 1965 is the key year.
And it's actually a massive expansion of social welfare, right? The enactment of Medicare and Medicaid. So how does the creation of Medicare structurally undermine a 183-year-old hospital system?
Well, it changed the fundamental mechanism of how vulnerable people accessed health care.
Okay.
Before 1965, if you were elderly or destitute or part of that urban poor in a city like, say, Baltimore or Seattle,
Right.
the Public Health Service hospital might have been your only realistic option for comprehensive inpatient care. You went there because the private hospitals would often turn you away if you couldn't pay.
Because they're private businesses.
Right. And the PHS hospitals were directly funded by the federal government to keep their doors open.
But then Medicare and Medicaid come along and introduce a fee-for-service voucher system.
Exactly. The federal government was no longer just providing the hospital building. They were suddenly providing the patient with the money, essentially, to go to any hospital.
Oh, wow.
So the elderly and the urban poor, who had historically relied on the PHS hospitals, they could now walk into almost any mainstream private community hospital in their city.
Because they have Medicare now.
Right. And the federal government would pay the bill through the new entitlement programs.
So naturally, the patients started leaving the PHS hospitals.
Many did, yeah. I mean, they sought care closer to home or at newer, more modern private facilities. And this triggered a completely devastating administrative logic.
I can see where this is going.
Right. The budget planners at the Office of Management and Budget, the OMB, they start looking at their spreadsheets.
The dreaded spreadsheets.
Yeah. And they see the federal government paying massive fixed costs, heating, lighting, maintenance, staffing to keep these really large aging PHS hospitals open.
Right.
But at the exact same time, they're paying Medicare and Medicaid claims for the exact same demographic of patients at private hospitals right down the street.
So they're basically paying twice, or at least it looks that way on paper. It's that classic problem of fixed costs in a declining market.
Precisely.
Like if you have a hospital built for 500 beds and the patient census drops to, 150 because everyone else is using Medicare at the private hospital across town.
The building is still the same size.
Exactly. It still costs almost the same amount. To heat the building, maintain the roof, keep the lights on, staff the core departments. So the cost per patient just absolutely skyrockets.
And to an accountant at the OMB, maintaining a separate, dedicated, parallel chain of government-run hospitals suddenly looked like incredibly costly, unjustifiable duplication.
It's kind of like, okay, think of it like building a highly specialized, heavy-duty off-road vehicle because you live in a place with absolutely no roads.
Okay, I like this.
Right. You need that off-roader to survive. But then the government comes in and pays the entire country.
Right. The roads are Medicare.
Yes. Suddenly, keeping that massive, expensive off-roader running, doing all the maintenance, paying for the special gas, it looks less like a necessity and more like an unjustified expense to the accountants.
That captures the bureaucratic perspective perfectly. The underlying infrastructure just became completely misaligned with the new economic reality of healthcare delivery.
Right.
But And the historical record makes this very clear. 1965 did not kill the hospitals instantly.
No.
The New England Journal of Medicine account describes Medicare and Medicaid not as an explosive charge, but as a slow solvent.
Man, that phrase, slow solvent, that is incredibly evocative.
It really is.
It implies this like structural weakening rather than a demolition.
Exactly.
Mhm.
The legislative rationale was basically gone, and the bureaucratic armor was stripped away. But the physical reality of the hospitals remained.
The buildings are still there.
The buildings were still there, the commissioned corps doctors were still there, and a lot of merchant seamen and local patients still preferred the continuity of care they received from the PHS.
Because it's what they knew.
Right. So the system was exposed to the elements, but it had enough historical momentum to keep limping along.
Limping along. But, you know, when a system is exposed like that and its core economic rationale is gone, it becomes a target.
Oh, absolutely.
Once the OMB decides an institution is redundant, the budget knives inevitably come out. And this brings us right into the 1970s. The 1970s are basically defined by this agonizing, drawn-out, recurring battle over the fate of these physical buildings.
Year after year.
Yeah. And the threat becomes explicit in 1970 when the Nixon administration floats a plan to simply close all the nation's public health service hospitals and clinics to save money.
Right. The Nixon administration was aggressively looking for places to cut discretionary domestic spending, and the PHS hospitals, with their dwindling patient census and high fixed costs, they were just a glaring target on the ledger.
Just sitting there waiting to be cut.
But what makes 1970 such a pivotal year isn't just the threat of closure. It's a simultaneous shift in how the federal government conceptualized public health intervention as a whole.
Okay, what do you mean by that?
Well, that exact same year, Congress passed the Emergency Health Personnel Act of 1970.
Ah, okay. This is the act that creates the National Health Service Corps.
Yes.
I really want to dig into the mechanics of this because it represents a total paradigm shift in American medicine, doesn't it?
It completely flips the model. Because the 1798 model was static, the government built a massive, expensive base of inpatient hospitals, like a castle, essentially.
Right.
And they required the sick populations to travel to those specific geographic points to receive care.
Come to us.
Come to the castle. But the new model, embodied by the National Health Service Corps, was mobile. It was decentralized. Instead of funding brick-and-mortar buildings, the government decided to fund the clinicians directly.
So the mechanism literally changes from funding the facility to funding the human capital.
Yes. The government would pay off the medical school debt of young doctors and nurses, and in exchange, they'd deploy them out into the world.
Like where?
They sent them to rural towns in Appalachia that hadn't seen a doctor in decades, or, to inner city neighborhoods with severe primary care shortages.
Taking the care to the people.
Exactly. So the philosophical future of the public health service was pointing definitively away from the old static hospital system and pointing toward this decentralized model of community-based preventive care.
Wow. But the problem is you still have these massive legacy assets just sitting there. The old hospitals are still taking up millions of dollars in the federal budget.
Yes, they are.
So the government wants to move to the new mobile model, but they are totally tethered to the old brick-and-mortar one. And this sets up an incredible tug-of-war between the executive branch and the legislative branch throughout the entire decade of the 1970s.
It became this grueling annual ritual, successive administrations, and it is vital to note that this crossed party lines.
Oh, really?
Oh, yeah. The Nixon, Ford, and Carter administrations all participated. They would propose budgets that aggressively targeted the PHS hospitals for closure because the executive branch saw them as an expensive vestige. But every single time the OMB tried to zero out the budget, Congress would intervene to save them.
Okay, let's talk about that. How did Congress actually save them? Because we always talk about Congress as this monolith, but there are actual mechanics and people behind these rescues. Who was pulling the levers here?
It was a fascinating coalition of regional and union power applying pressure to the appropriations committees.
Okay.
First, you had the maritime unions, like the Seafarers International Union. Now, even though merchant seamen were a much smaller percentage of the patient population than they were back in the 1800s,
Sure.
these unions were politically sophisticated, and they were deeply protective of their historical statutory right to federal care. They lobbied aggressively.
Because giving up the hospital meant giving up a hard-won benefit. Once you lose it, you don't get it back.
Exactly. It's a union benefit. Second, you had the mayors and local politicians of the port cities themselves.
The places where the buildings were?
Right. Places like Seattle, Baltimore, Boston, Staten Island. These hospitals were major local employers.
Oh, right. It's not just the doctors, it's the janitors, the cooks, the admin staff.
Exactly. They were economic engines in their specific neighborhoods. And remember, they still provided a massive amount of uncompensated care to the local urban poor.
So if it closes, that burden falls on the city.
Yes. A member of Congress representing Staten Island could not simply allow the executive branch to shutter a massive local employer and dump all those patients onto the city clinics.
No way.
So they used log rolling, committee assignments, and political leverage to ensure the PHS hospitals received an appropriations rider for just 1 more year.
A 1-year stay of execution.
Basically.
And there's a third faction in this coalition too, right?
Yeah.
The commissioned core of the Public Health Service itself.
Yes. The uniformed medical officers who staffed the wards, and we really need to understand their unique culture.
Yeah, because they wear uniforms, which is interesting for doctors.
Right. They were established in the late 19th century as this mobile, quasi-military force of doctors, scientists, and engineers designed to fight epidemics like yellow fever and cholera.
Wow.
They wore naval uniforms, they had ranks. And the PHS hospitals were their standing clinical home. It was where they trained, where they practiced, and where their entire institutional culture was forged.
But wait, I have a question about this. If this coalition, the unions, the mayors, the uniformed officers, if they were powerful enough to force the hands of multiple presidents and secure these reprieves year after year, why didn't they just pass legislation to secure permanent, unassailable funding?
That's the logical question.
Right. Like, why force this institution to live on a year-to-year stay of execution? They had to know that eventually the political winds would shift and the budget acts would inevitably land.
It comes down to the nature of borrowed power in Washington.
Borrowed power.
Yes. The Public Health Service was, structurally speaking, a low-power agency. They did not have an independent, dedicated tax base like the Social Security Administration.
Oh.
And they did not have the untouchable cultural status or the massive, geographically dispersed defense contracting lobby of the Pentagon.
Right. They aren't building fighter jets in 50 different states.
Exactly. Their power was always lent to them by the government to solve specific problems at specific times.
So they survived on the margins of the budget.
Entirely. They were entirely at the mercy of the annual appropriations cycle. A local congressman could muster the specific political capital to issue a 1-year reprieve to appease the mayor of Seattle or a union boss.
Sure.
But Congress lacked the collective national political will or even the overarching policy rationale to enshrine a permanent, heavily funded parallel hospital system in an era where Medicare was already supposed to be handling the burden.
Right. They couldn't justify fundamentally rebuilding it.
No, it was politically easier to just keep the hospitals on life support, deferring maintenance, letting the building slowly decay rather than fighting the massive uphill battle required to fully revitalize them.
Easier to keep them on life support. That really explains the slow starvation we're talking about. I mean, you can picture it. The roofs are leaking, the x-ray machines are aging, and the budgets are just flat. And meanwhile, 1970s inflation is just eating away at their purchasing power.
It was a very bleak time inside those buildings.
But, and this is where the story gets really fascinating, while Congress is tossing just enough pennies to keep the hospital lights flickering, the real wealth, the real prestige, and the massive influx of federal public health dollars was quietly moving next door.
Yes.
And this brings us to the rise of the offspring, the National Institutes of Health and the modern grant economy.
Because to understand the diminishment of the direct care hospitals, we really have to look at what was gaining power simultaneously.
Right. Where did the money go?
Exactly. In 1971, President Nixon signed the National Cancer Act.
The famous War on Cancer.
Yes, the legislative launch of the War on Cancer. And it channeled massive, unprecedented new funding into the National Institutes of Health, the NIH, for targeted biomedical research.
Okay, so this isn't just a story about money moving around. It's a story about the migration of prestige. We are looking at a stark contrast between two very different philosophies of medical work here.
Very different.
On one side of the ledger, you have the public health service hospitals. They are doing the unglamorous, gritty, deeply necessary work of frontline direct care.
Right.
They are treating merchant seamen for chronic back pain, setting broken bones, managing advanced diabetes for the urban poor in these aging, drafty brick buildings in industrial port neighborhoods.
And on the other side of the ledger, you have the NIH campus in Bethesda, Maryland.
Yeah.
Gleaming new laboratories, the allure of cutting-edge, high-tech science, the pursuit of the cure for cancer. The NIH was producing breakthroughs, generating major national headlines, and winning Nobel Prizes.
And from a purely political standpoint, the calculus is obvious. I mean, politicians love to stand next to a Nobel laureate or announce a multi-million-dollar breakthrough in cancer research.
It's great optics.
It's amazing optics. It is an infinitely harder political sell to call a press conference, to brag about, hey, we kept an aging, leaky hospital in Baltimore open for another 12 months to treat routine ailments.
You don't get reelected on that. And the mechanism of how this new money was spent is also crucial.
Okay, let's get into the mechanics.
The transition from direct hospital funding to the modern grant-funded economy, it fundamentally remade American medical research.
How does a grant economy actually work compared to the old system?
Well, in the old direct care system, the federal government owns the hospital, pays the electric bill, and directly employs the doctors and nurses on salary.
Right, it's very contained.
It is heavy, bureaucratic, and physically static. But in a grant economy, the federal government doesn't own the labs or hire the researchers. They act as a massive clearinghouse for capital.
Oh, I see.
They dispense billions of dollars in grants to universities, academic medical centers, and private research institutes across the entire country.
Which creates an incredibly powerful new political constituency.
Precisely.
Yeah.
If the NIH gives a $10 million grant to a university, that university takes a significant percentage for what they call overhead or indirect costs.
Right.
And that pays for their buildings and administration. Suddenly, every major university and academic medical center in the country is lobbying Congress to increase the NIH budget because their own institutional survival depends on it.
Wow.
The federal government realized it could achieve massive public health goals and generate immense political goodwill, not by employing doctors to run wards, but by feeding the biomedical research grant machine.
It's the ultimate outsourcing of public health intervention. You know, it reminds me of that university analogy we discussed earlier.
Yeah, bring that back.
It's like the old PHS hospital system is the original unglamorous undergraduate teaching program. It does the hard work of educating the locals. But then the university administration figures out how to build this multi-billion-dollar research park on the other side of campus.
Right.
And the research park brings in federal grants, corporate partnerships, prestige, and over a decade, the massive research park becomes a complete colossus, while the original teaching program is totally starved of cash. The buildings fall into disrepair, and it can't even afford to hire new adjuncts.
That is exactly what happened. The parent service was hollowed out while its research offspring was fed.
Wow.
And it's really important to remember that historically, the NIH grew out of the public health service.
Wait, really?
Yes. The original hygienic laboratory, which became the NIH, was established at the Staten Island Marine Hospital in 1887.
I had no idea.
It was literally the child of the hospital system. But by the 1970s, a massive transfer of bureaucratic power had occurred. The overall federal health budget was actually growing, but the money was flowing entirely toward the research offspring.
And a starved parent can only survive on life support for so long. Eventually, those year-to-year legislative reprieves run out. You know, the maritime unions lose some political clout, the mayors get distracted by other crises, and you can only dodge the budget axe so many times before it finally lands.
Yes.
And this brings us to 1981 and the locked doors.
So the bureaucratic stage for the final blow was set in 1980. The department overseeing the public health service was reorganized. The education components were split off, and it was renamed the Department of Health and Human Services, or HHS.
Okay.
By 1981, the newly elected Reagan administration was in power, and the secretary of HHS was Richard Schweiker.
And the Reagan administration came into power with a very specific, aggressive, and frankly highly publicized mandate to slash domestic spending and drastically reduce the footprint of the federal government.
That was their whole platform.
Right. They weren't interested in maintaining vestigial New Deal or 19th century infrastructure.
Yeah, no, they were not. And they achieved this closure through a specific legislative mechanism, the Omnibus Budget Reconciliation Act of 1981.
Okay.
This is the crucial mechanical difference between the 1970s and 1981.
How does an omnibus reconciliation bill bypass all those local mayors and unions who had successfully saved the hospitals for an entire decade? Like, how does that work politically?
It's all about how the bill is structured. An omnibus reconciliation bill is this massive, sprawling piece of legislation that bundles thousands of disparate budget cuts and policy changes into a single, massive package.
Oh, I see.
In the 1970s, the fate of the PHS hospitals might be debated as a single line item in an appropriations committee where a local congressman could say, hey, I'll trade you a vote on this if you protect my hospital.
Well, you can negotiate it separately.
Exactly.
Okay.
But the 1981 Omnibus Act was managed by David Stockman, Reagan's budget director, and he weaponized the reconciliation process. He packed the closure of the PHS hospitals into a bill alongside cuts to food stamps, education, and hundreds of other programs.
Wow. So it forces a single up or down vote on the entire package.
Exactly. A representative from Seattle couldn't vote to save the Seattle PHS hospital without voting against the entire federal budget and defying the new president's central economic mandate.
They were trapped.
Completely. The logistical maneuver basically severed the hospitals from their political protectors. Signed into law on August 13, 1981, the act explicitly mandated the closure or transfer of the remaining PHS hospitals and clinics.
And the timeline they imposed was absolutely brutal. The deadline for closure or transfer was October 31st, 1981.
Less than 3 months.
Less than 3 months to dismantle an institution that had been operating continuously since 1798. I mean, that is breathtakingly fast.
It was a shock to the system.
I want to read the roll call of the fallen here, because it is vital to recognize the physical geography of what was lost in the fall of 1981. We're talking about the final 8 general hospitals that either went dark or were hastily pushed off the federal ledger and handed over to local entities. Baltimore, Boston, Galveston, New Orleans, Norfolk, San Francisco, Seattle, and Staten Island.
And the dispersal went much deeper than just the general hospitals, too.
It did.
Yes. The system also lost the Carville National Leprosarium in Louisiana.
Oh, Carville. Carville is such a unique and, honestly, heartbreaking part of the story.
It really is. It was a facility with a profound, highly specialized history of treating Hansen's disease or leprosy.
Right.
And because of the intense social stigma surrounding the disease, Carville functioned almost as a self-contained society for decades. The patients formed a deeply tight-knit community, and the federal government provided comprehensive, lifelong care and sanctuary.
Wow.
Passing it out of the direct care system unraveled a safety net that was entirely unique in American medicine.
That's devastating.
It was. Additionally, roughly 2 to 3 dozen outpatient clinics across the country were shuttered or transferred. As that New England Journal of Medicine piece stated, one of the most colorful and productive eras in American medicine had come to an end.
Yeah. And, we can talk about omnibus acts and the migration of grant money and legislative maneuverings all day long. But if we're going to do justice to this history, we really have to ground it in the human texture of the moment.
I agree completely.
We have to look at the human consequence of those locked doors in October 1981. Like, think about a merchant seaman who had spent 40 years on the water. A man who knew exactly where to go in Seattle or Galveston when his knees finally gave out or when he contracted an infection in a foreign port.
Right.
Those sanctuaries, which his union had fought for decades to protect, were simply gone.
And consider the urban poor. In the early 1980s, many of these port cities were already struggling with severe municipal budget crises and deindustrialization.
Right, the 80s were tough for cities.
Very tough. Handing these massive federal hospitals over to local control or closing them entirely added immense immediate strain to local safety nets that were already fraying.
But the group I just keep coming back to is the Commission Corps.
Yes.
Imagine being a dedicated public health service doctor or nurse. You wear the uniform. You have committed your entire professional life to this service. You show up for your shift in San Francisco in November 1981, and the heavy doors to your clinical home are simply padlocked.
Just locked.
What does an army of doctors do when you take away their battlefield?
It created an acute existential crisis for the Corps. We talked earlier about how the physical hospitals were their standing clinical platform. Without the hospitals, they lost the very home base that allowed their doctors and nurses to practice medicine, to train the next generation of officers, and to maintain their distinct institutional culture.
Right.
They were suddenly officers without a command. Many were forced to hastily integrate into other federal agencies or disperse into the mobile National Health Service Corps. It fundamentally altered the identity of the service forever.
Because they don't have a place anymore.
Exactly. They went from being the administrators of a vast physical healthcare system to being a dispersed pool of medical talent.
So, now that the wards are empty and the institution is dismantled, how do we, as observers of history, categorize what just happened. When we look back at the whole sweep of this from 1965 to 1981, how should we understand it? Because the historical dossier we are working from has a very specific warning for us here regarding how we frame this narrative.
It does. It urges us to resist the temptation of melodrama.
Melodrama, okay.
It is very easy, and perhaps comforting in a narrative sense, to label this a classic rise and fall story. You know, the tragic destruction of a great noble service brought low by villainous, short-sighted budget cutters.
Right, the easy Hollywood narrative.
Exactly. But the truer story is much quieter, sadder, and significantly more complex.
Because framing it as a rise and fall implies that there was a zenith where the PHS was this unassailable fortress that was sieged and destroyed. But that ignores everything we just analyzed regarding the mechanics of the federal budget.
The logic of borrowed power is the absolute key to understanding this diminishment. The Public Health Service was perennially a low-power agency.
Right, they never had their own guaranteed base.
Right. Their power was always lent to them by the government to solve specific problems at specific times. First, the sick sailors driving the maritime economy, then the urban poor, then the need for a standing medical reserve. When they finally lost their one tangible brick-and-mortar asset, the hospital system, they lost it the exact same way they had always been vulnerable to losing things, to whoever controlled the budget at that specific moment in history.
Wow. And we need to be incredibly clear about the politics of this starvation, too. While the final executioner's blow was the 1981 Omnibus Act under the Reagan administration, the starving of the system was a decades-long, strictly bipartisan effort.
Oh, absolutely.
Democratic and Republican administrations alike looked at those budget line items in the 1970s, looked at the fixed costs, and tried to cross them out.
The push toward the NIH grant economy, the shift toward mobile clinics, the reliance on Medicare, this was championed by both sides of the aisle. It was a consensus of the bureaucratic class. The era of direct federal hospital care was deemed over by the people writing the checks, regardless of their political affiliation.
So what does this all mean for you listening to this right now? Like, why should you care about the closure of an old hospital in Galveston or Boston 40 years ago?
It's a valid question.
It is. And I think it's because it shows us the actual mechanical anatomy of how institutions die. They don't usually die in a single dramatic explosion.
No.
They die from 15 years of redirected priorities. They die from quiet budget knives, from inflation eating away at flat funding, from deferred maintenance, and from shifting cultural definitions of what society considers glamorous, innovative, or essential.
That's the real takeaway.
It forces us to look around our own landscape today and ask, what essential services right now are quietly being starved just because they aren't producing headlines or generating massive economic spin-offs?
Right. We frequently confuse the loss of physical infrastructure with the disappearance of resources. But as we've seen, the resources didn't vanish into the ether.
No, the money just moved.
The federal health budget grew astronomically. The resources just migrated to where the political prestige and the new economic mechanisms were most powerful. Recognizing that pattern of migration, rather than just focusing on the destruction, is essential for understanding how government actually functions.
Let's pull all these threads together. We have traced an incredible 183-year journey today. We started in 1798 with the young republic recognizing that it had to build marine hospitals to care for the sick sailors who drove the economy.
Right.
We moved through the 20th century where the system expanded into an urban safety net. Then we hit the slow solvent of Medicare in 1965, which removed the bureaucratic armor and emptied the wards by giving patients a voucher to go elsewhere.
A huge turning point.
We navigated the grueling, decade-long tug-of-war of the 1970s, where administrations tried to kill the hospitals based on their fixed costs, and local politicians offered last-minute reprieves through committee leverage. And we saw how, during that same period, the real money and prestige flowed toward the gleaming biomedical labs of the NIH and the new academic grant economy.
And finally, we witnessed the rapid culmination of that starvation in 1981 when the Omnibus Budget Reconciliation Act bypassed the local political protectors and forced the brutal 3-month closure of the last 8 hospitals and the Carville leprosarium, ending a nearly 2-century mission of direct care.
It is a profound structural shift in the architecture of American public health. But before we close this deep dive, there's a final lingering thought from our historical research that I want to leave with you to mull over. It's about what remains and what is irrevocably lost when a system undergoes this kind of transformation.
The Public Health Service Commission Corps survived the cuts of 1981. They kept their naval uniforms, they kept their ranks, and their offspring agencies like the NIH and the CDC went on to become immensely powerful, globally recognized institutions. But they lost the physical buildings that gave them a direct daily connection to the suffering public. And this raises a vital question for us to consider. When a public healthcare institution is forced by budget mechanics to abandon the unglamorous frontline brick-and-mortar work of actually touching patients and instead retreats purely into the realm of administration, policy, and distant research grants.
Yeah.
Even if that scientific research is groundbreaking and saves millions of lives in the long run, what irreplaceable human element, what sense of grounded duty is lost from our public health system forever?
It's a haunting question. You can fund all the brilliant academic research grants in the world, and you can draft the most efficient Medicare reimbursement policies, but eventually someone has to be there in the room to set the broken bone or treat the fever.
Someone has to do the physical work.
Right. Remember that 183-year-old building with the deep foundations and the heavy doors we talked about at the very beginning. The doors are locked, the wards are empty, and the institution has moved on to higher tech pursuits. But the physical need for what happened inside those walls, the need for a sanctuary for the vulnerable, never actually disappeared. Thank you for joining us on this deep dive.